We don't have that restraint. So I'm going to stop us throughout the video and I'm going to tell you what questions I would have asked behind closed doors. I probably have something like 500 quotes and interviews about Medicare healthcare cost planning. Today, we're going to have a watch party with Dr. Oz and my friend Bob Powell. Bob's got a tough job. Bob's got a real tough job. He's got to play nice. He knows what the questions to ask are. He knows the line on what questions can't be asked. Just a couple of days ago, he interviewed Dr. Oz, who is the head of the CMS Centers for Medicare and Medicaid Services. Paid subscribers to Jay's Corner, they heard the questions that I would have asked, the tougher ones. Bob didn't have that luxury. Let's watch the interview. I'm going to interject. Before I forget, the book is Maximize Your Medicare. MaximizeYourMedicare.com is the domain. New edition will be coming out in the autumn. You can buy it anywhere a book is sold. You can find it in over 1,000 libraries in the United States. Let's get to the interview.
Healthcare of 150 million plus Americans. In his new role as administrator, he is going to lean into technology, into AI, and deliver medicine in ways that have never been delivered before. But the big question is, who's going to pay for all that? Well, that's what we asked him in the latest episode of Decoding Retirement. Take a listen. So welcome, Dr. Oz, to Decoding Retirement. We're happy to have you here.
Thanks for having me. Lots to talk about.
We do have a lot to talk about in a short period of time. So let's start here. You mastered the art of explaining complex medical concepts to millions of people on your television program. And now you're running a complex agency with where you're responsible ultimately for the health care of millions of Americans, 150 plus million Americans. And curious, what's your strategy for translating that, that same clarity to an agency where a single memo could affect 66 million Medicare beneficiaries or 78 million Medicaid beneficiaries or millions of people on ACA? What's the strategy?
Well, the one job you didn't mention was being a heart surgeon. And actually that as well has some overlap with hosting a TV show and running a government agency. There's different amounts of blood in each category. I may be in the bloodiest terrain right now, the harshest theater. But I do believe it's the best job I've ever had, in part because much of what I've done in my life, and I do adore heart surgery, and the hosting a show was just a blissful event every single day. But much of what I do now is to take those skills and allow them to be, affect billions of Americans, as you mentioned. Many times those Americans feel like they've been left behind. At my very core, what I've always felt was I wanted to be in the change business. A lot of listeners probably feel the same way. You don't just want to go up every day and do your job and go home. You want to get up and do things that change the course of human history. At least we like to think that. And that's certainly what I think all of us are put on earth to do, is make a difference. So within this space of healthcare, there's many ways to do it. But something that I learned from my producers on the show, and it's a very powerful insight, is people do not care what you know until they know that you care. Mm-hmm. And so starting off with the emotional hooks about why this message matters and why what we're doing is so important is the best way generally to start any conversation. So with your permission, I want to just share a quote that's present at the entrance of the building that I work in with Secretary Kennedy and a bunch of other colleagues in Washington. It's called the Humphrey building. And Hubert Humphrey made this statement 50 years ago. By the way, Medicare and Medicaid, 60 years old this week, which we'll talk about. So this precious gem, this backbone of the social safety net system was created 60 years ago. And because of drift or maybe by design, there have been lots of changes to the program. But we should always remember this quote from Hubert Humphrey. And it emphasizes it is the moral obligation of government, the moral obligation to take care of those at the dawn of their life, the children, those at the twilight of their lives, the seniors, elderly, and those living in the shadows. And that haunting use of light that Hubert Humphrey was proposing, we judge the purposes of Medicaid in particular, but it applies to Medicare and CHIP, the Children's Health Insurance. It applies to the Affordable Care Act. It even applies to commercial insurance, which we don't control, but private companies offer to their employees. That's the goal. That's what insurance is about. We pool our resources. We pray we don't get sick, but if we happen to have the bad luck of an illness, then you have to manage that. And that's fundamentally why all this that matters. And retirement is made much richer if you're healthy enough to enjoy it. You cannot be a healthy country if you're not if you're not doing these issues, and you can't be wealthy if you're not healthy. It matters that Americans are healthy enough to live and work longer. And I'll give you one just tangible example. If you were born in 1964, you are now 61 years of age. It turns out the average American retires at age 61. So if I can get you to work an extra 3 years, from 61 to 64, the value to our GDP is $1 trillion. $1 trillion just by one group of people born in 1964 working 3 years longer. So that means we got $300 billion in taxes from that $1 trillion of incremental value to the GDP. So this is how I think about the investment in health.
So let's stop here, right? This is not wrong factually, right? Work longer, pay more taxes for longer, the system gets more money. No problem. The issue here is white-collar recession and ageism, right? Meaning that you're 61 years old and you are a middle manager at a Fortune 500 company. You've been recently laid off due to downsizing. You know already there is a very high likelihood, very high, that you will not find another job. That is just the way today's world works. And there's this question between that period, it becomes the most risky period. Go to the newsletter. That's largely for you on how to attach ACA, because that's the bridge here between 61, let's just say in Dr. Oz's example, and then becoming Medicare eligible. Let's continue.
Make America healthy, we will be a richer country for it, literally.
Yeah, there's a lot of talk now about increasing health span, compressing morbidity, et cetera, et cetera. But you mentioned the Humphrey quote, and I'd love to turn your attention to the One Big Beautiful Bill, where there's some controversy around how many people might not qualify for health insurance or Medicaid, given the potential work requirement that will be put in place. I'm curious, your thoughts on that. Like, for me, as I think about all that I've read about this topic, is most of these folks are working either full or part-time, and it might be the red tape, right, that sort of bogs them down from getting the health care that they need. And in light of what you just said about Humphrey, it seems like we might not be fulfilling that promise.
Excellent place to go, because I think it highlights some of the arguments that happen in healthcare. So the primary goal of Medicaid was to take care of the people identified by Humphrey. None of those categories are touched by the work requirement, because it's not even a work requirement, it's a community engagement. Are you willing to commit to try to get a job, get an education, support your community, take care of kids, do something that shows that you actually have agency over your future? So if you're in one of those early categories, if you're a child or seniors in poverty, or if you're living in the shadows because you've got a chronic illness or some other reason that you can't work, you're already in. The purpose of what was done to take the fraud, waste, and abuse out of Medicaid was to preserve it. The expenses have gone up 50% in 5 years. That is just not sustainable. And so rather than shut the program down in some future administration, the president said, clean it up. Take out the stuff that's not supposed to be there. The most obvious was a work requirement, which most people, if they think about it, and this has been surveyed, 100% agree. If you're living in someone's home and they come home at night after they worked all day long and they're paying your health insurance, and they say, will you chip in? Because, like, help around the house, try to get a job, go get an education. Don't do what you're doing now, which is on average an able-bodied person on Medicaid, who was never supposed to be on Medicaid originally. An able-bodied person on Medicaid who's not working watches 6.1 hours of television or video games or just hang out around the house a day.
So this is the issue, right? I mean, someone gets on a roll, I get on a roll, right? I've been with Bob many times. I start talking and then slip in a phrase. Okay. So there's information to say that a lot of the people who are on Medicaid are already those who cannot work. I'm not a demographic or what, I don't have perfect data, right? There's going to be anecdotal evidence, et cetera, et cetera. We don't know who's making what data up. right? If you ask Kaiser Family Foundation, they're going to tell you that a lot of the Medicaid recipients are either already working or actually can't work. Let's just call them disabled or challenged in some way that prevents it. And yet this gets glossed over. It's not Bob's fault. But my point is, you're letting people go and slide in these phrases that kind of go unchallenged. Nothing more than that. I don't have any statement about whether the data is actually right. Because if you're talking about a bunch of freeloaders, then I think everybody can agree. If you're talking about the people who cannot work or who are already working at jobs where they cannot possibly afford health insurance, that's different to me.
6.1 hours a day. That's not a way to live your life. And it turns out when you give the American people that challenge, and I have confidence in the American people, I suspect you do too, most listeners as well, they take it. When over the last year and a half or so, there have been 15 million people who have come off the Medicaid rolls who were left on there during COVID because nobody was asking questions about whether you belong on Medicaid. Of the 15 million people, 90% got other coverage somehow. So the average American understands it's a sweetheart deal to get free health insurance, especially if all we're asking you to do is make your life better.
Right.
And that's why I am confident it's ethically and morally the right thing to do. But it also will help preserve a program so the people that Hugh and Humphrey spoke about, the people for whom 60 years ago Medicaid was created, they're protected. And
I'm going to stop here. So I'm not here to settle political or philosophical differences, right? In other words, this is wandering to me into the area where what's morally or philosophically correct. Okay? We're not here to settle. And I'm just going to tell you, the book above my head there, Jay's Corner, these are not here to settle political or philosophical differences. Why? Because that creates noise. You don't get the right facts. The noise is so loud, you can't hear the facts, right? Because that's what we have to deal with in front of us today. And it doesn't matter how much money you have. It does matter, what health you have. So as a result, you get this convergence, and yet what you are doing here, and this happens in interviews, is that especially when there are people affiliated with elected officials, out come, platitudes, moral platitudes.
you know why there wasn't a work requirement back then? It never dawned on anyone's mind that you would ever give free health insurance without asking people to try to chip in if they were able to. And if you look at every other social program, we have work requirements. In fact, President Obama, President Clinton, President Biden all said, Democratic presidents, as well as Republican presidents, obviously, have all said that the backbone of a social network program, of a social safety net program, is a work requirement. It's good for the people in the program. And the welfare reforms of President Clinton back in the 90s showed that when you challenge people, they get jobs and they get out of poverty.
We're going to take a short break. We'll be back with Dr. Oz, the head of CMS, right after this.
I don't know about you all. I'm exhausted already, right? So this first half here has been talking about Medicaid, the fact that there's going to be a new work requirement in order to get Medicaid. Okay. It has left untouched health programs for children. Okay. So for those people where your child is covered by Medicaid from your state in which you live, that looks to be untouched, unscathed. That said, work requirement is here, on top of the fact that you're going to have more frequent checks to verify that you are eligible for the Affordable Care Act with the tax credit. The rest, I don't. Y'all know me here, right? To newcomers, welcome. To people who have been here other times, seen other videos. I don't love when someone tries to put on, their sanctimonious clothes and start, preaching to us, right? You're an adult, you're your own agency, no problem.
Not recently that talked about in Georgia where there is a work requirement and how people who are working but who failed to fill out the paperwork then became disqualified. Do you worry that maybe that impediment, that red tape, would prevent people from qualifying for Medicaid who might otherwise qualify but were it not for the paperwork?
So we are so focused on that issue, we've already launched 2 pilots
Yeah.
in Louisiana and in Arizona, which have had good results so far. And we're going to broaden it out. I was speaking this weekend to the National Governors Association, and I asked a few more states to join the pilot. The people running it are the same folks who fixed the passport system in America. If you haven't tried to get a passport recently, there was actually a positive article about the administration in the New York Times because the passport system works now. Within 2 to 3 weeks, you can get a new passport. You don't have to go to a post office or a drugstore for photos. It's all done digitally. So we have the same team run by Amy Gleason, United States Digital Service, and they have already started the pilot. And it's very simple. 91% of people on Medicaid have smartphones. You tap on the smartphone within the app where you're working. Let's say you're an Uber driver. It knows that ADP does your payroll. And so it asks you permission. Can I contact this ADP company and ask them about your hours? You say yes, and boom, within 5 minutes, the entire process is less than 7 minutes. You have all your numbers. You just confirm that it's okay. And I'll go one step further, Bob. This is what I'm excited by. And I talked about this with the governors this weekend. Into that system, let's make it better. Let's connect you to the employment office of the state if you haven't gotten to 20 hours. So again, we're only asking you to work half-time. You don't have to work full-time, even if you're able-bodied, just 20 hours a week. But if you're short 3 hours, maybe we can get you a job in an area that you have expressed interest in because you're already working in other odd jobs doing that. And that's how you get people into full-time employment. And then they get off Medicaid. They're not trapped in the system. They go into the exchanges and they go up into commercial health insurance and they live fulfilling lives. I want to avoid the crisis that's been faced by many European countries, where in an effort to be nice, they give support to folks who then forget what it's like to work. If in the United Kingdom, which is a good example, you have generations.
The phrase got slipped in as if the person would qualify for health insurance from the employer. That is not the case, right? If you work at a large employer, you would know this. If you started a new job at a large employer, you would have a certain time lag, right? Up to 90 days. That's the legal maximum. Let's call it 2 months. So you have to be working. And in addition to that, part-time employees usually don't get access to the company-sponsored health insurance program. These are these details that are, kind of get glossed over. Someone's talking at high speed. Interviewer doesn't want to interrupt it at little factual inaccuracies. And then go on as if that's the truth to an unknowing public.
Trapped poverty, where your grandfather didn't have a job, your dad didn't have a job, you've never had a job, your son doesn't have a job, and no one you know has a job that you're related to. So it's not part of the culture anymore. In America, we always worked, and we need workers. So it's good for you, it's good for the country, it's good for the healthcare system.
All right, I want to turn my attention. You mentioned fraud, abuse, waste. When I think about Medicare Advantage, we've got serious problems there, right? The Wall Street Journal has had a number of stories that exploited, where companies are exploiting the system, collecting billions of dollars in taxpayer dollars. United Health just admitted that it was the Justice Department was investigating it. I feel like we've handed over our healthcare to a private industry and to ill effect.
So, Bob, this is a very sensitive topic for everybody because the whole point of launching Medicare Advantage was to give seniors options. You want to take a regular fee-for-service Medicare, which is out there and used by half the population, or do you want to use an HMO version, a managed care version that would, if theoretically, offer some benefits? They maybe do a better job in streamlining your care. They could give you supplemental benefits. They could help with your prescription pricing. They could give you things that would make your exercise classes, food support. And so Americans have sort of divided in half over this issue.
Okay, so let me first say that there's nothing wrong with this. Okay, the idea that Medicare Advantage is always bad is just simply not the case. There's the rationale there. This is the case for Medicare Advantage. There's going to be more in a few moments, but this is correct. right? In other words, they're looking for outcomes. We need efficient outcomes. We need to push down the systematic cost of healthcare services in the United States. You get no pushback from me so far on everything that he said.
Issue. In the middle of all this, if it turns out that Medicare Advantage is costing us a lot more than fee for service, you're violating the whole premise.
Right.
The whole argument was, we'll give a private company a little money if they drive down overall costs and improve quality. So
the issue here is we're going to give them a little money, but some of that money is for some of these other benefits. Right? So I'm not sure what the easy answer is, right? I don't have the easy answer here. My point is only that, okay, to say to an individual who's on Medicare Advantage or on a $0 PPO, and all of a sudden you think that the entire system is bad and you should avoid it. Well, if you're living check to check on Social Security alone, you're Mr. or Miss Perfect, never sick. These extra benefits matter because you need to go to the dentist. You have bad eyesight like myself. There are other benefits on top, and that's being wrapped into the overall cost here of Medicare Advantage. That, to me, is glossed over here.
oh, if you believe the government does it better than anybody else, then stay with them. If you believe that a private venture, let's look at the mail system, right? You could use the U.S. Postal Service, you could use FedEx, right? So you have choice. And if you think FedEx is worth it, you give money to them. If not, you won't. In Medicare Advantage, I do think that there's been an ability for the companies, the private companies, to game the coding system. And by that,
Okay. I'm not going to dispute this is the case. I've written a lot about it. The pathway here is this risk coding system that Dr. Oz mentions, right? In other words, this happens in every walk of life. Contractor on request for proposal to City Hall for a new construction site, right? They say they have X million dollars. The contractor knows it could cost Y, which is lower. So they try to dress up their proposal in order to make it better for the city as a whole. And now, after the fact, they say, okay, the price of X was too high. And that's kind of what's going on here. Whether they're doing so like blatantly, illegally, and fraudulently is the open question.
I mean, obviously, if you're an insurance company, you want to know how sick your patients are. So instead of just saying, I got what I got, I'm going to take care of them, and I'll just be honest about how sick they are, they expertly devised tactics to upcode, to pretend the patients were sicker than they really were.
Right.
That got them more money. It got them shits that they can use for other purposes, and they were able to take profit off the table. We obviously are examining that. We have a process called RADV, that allows us to go back into the late teens and for the first time audit Medicare Advantage companies. And based on what we find, we're going to pull money back from them. We expect it will be billions and billions of dollars.
Let me turn my attention, because I know we have short time, to Medicare Part B. The most recent trustees report suggests that.
Okay, before we get there, let's just keep going here. So the idea of clawback is true, and the carriers have pushed back on it. They've lost. In addition to that, the star rating, how much money goes from the government to Medicare Advantage carriers is based off a certain grading system. Okay, one of those grading systems is the star system. And that's what the point of the star system actually is. Extra money to those carriers and plans who have been rated more highly. That means the next year they have a bigger number by which to add extra benefits, which you may or may not use, right? And on it goes. I've stated, look, why don't we flip this on its head, which is let the carriers compete at the clearing price, and that single clearing price be charged to everyone. We have that today. in other walks of life, where, for example, when the United States auctions treasury bonds off, guess what the mechanism is? Just what I just described.
Part B premium will rise 11.6% next year, and that we're projected to keep that percentage increases far in excess of average inflation over the next till 2033 or so. And some of it is due, I believe, because hospitals are now moving to outpatient care, which is a Part B cost, not a Part A cost. How do we rein in what's going on with Part B premiums? Because that obviously comes out of people's Social Security benefit checks.
So you have a very smart audience, but just we're all on the same page. I'm going to go through the letters real quick so everyone's together with us. So Part A is the 2.9% that comes out of everyone's paycheck every week that you get a pay stub. That pays for the hospital bill. A is in alpha. B is in boy, outpatient. Also some drug infusions like chemotherapy, for example, that's associated with hospitalization, done in a doctor's office or in the hospitals. Part B is in boy, doctor's expenses as well. Part C is the Medicare Advantage we were just talking about. And Part D, which we might talk about, is a drug. D is in drug, is the drug benefit that seniors are eligible for. So we have a major concern about Part B price increases, but we have a concern about Part A and Part C and Part D. So Part A, before I get to your question, the Medicare Trustees Report predicts it is bankrupt in 2033. Yeah. That's 3 years shorter than we thought even a month ago. And in their worst case scenario is that it goes bankrupt in 29. Now, we're not going to let that happen. But to fix that, you got to take some steps. And that's why some of the things we're doing are not popular with folks who get paid, not the beneficiaries, not the American people, but the folks who are getting paid from these programs are getting haircuts, and that's uncomfortable. Part B, which is what you asked about, is concerning because drug prices have increased so much. But there are other things that are in Part B as well that we believe we have control over and we could get to be more efficient. A lot of this is hearing the stakeholders and then pushing back on what you've heard, and then letting them actually come up with some ideas themselves. I had an op-ed this week with Marty Makary in the Wall Street Journal, and it talked about the power to convene. You mentioned prior authorization a little earlier. We went to all the major insurance companies, and we said, listen, we can do this with a sledgehammer and fix this issue that's frustrating the American people. The idea that you have to have all these prior authorizations for anything you want to do with your doctor. Or you guys can be adults and go fix this problem. In fact, the words we used was meek. You know, in the Bible, it speaks to the meek inheriting the earth. Meek doesn't mean weak, which is what I thought when I was a kid. Meek means you're armed with a sharp weapon, a sword, and you decide to sheathe that sword, put it away just for now, so you and your colleagues can come up with a better solution. So we're going back to hospital systems and drug manufacturers and the prior auth guys, the insurance companies who cover now 80% of the American people. In the case of prior authorization, they voluntarily came up with a nimble solution. They're being transparent in their efforts. They're dramatically reducing the number of prior authorization claims, and they're going to do it much faster. So you know almost immediately that you're not going to be stuck for 3 weeks waiting to find out if you can get your operation or not that's diagnosed cancer. So all this is part of the process. With the Part B program and with the Part C, a little bit with the Medicare Advantage, and even with Part D with the drug companies for outpatient drug use, we've gone back to all of them and said, we need better answers. And what you're doing now is making you a lot of money, and you can do that for another year or two, and then the bottom's going to fall out. So maybe you want to do it with us. Come work with us. Don't make us use a sledgehammer. Figure out these issues. Come to us with better ideas. Be transparent about them. The American people will love you for it. The president won't come after you because he will otherwise. And the president's very clear about this. He does not want the American taxpayers abused, and more importantly, doesn't want the American people abused. And some of these processes have become abusive. You know what works, Bob, really effectively? I will often go to a group of healthcare professionals, especially executives of companies, and I'll say, you went into this business because you care about people. Somewhere in your psyche, same as you did, Bob, when you entered the pharmaceutical space early in your career, you went into it because you thought these drugs would cure disease and save human lives. Sometimes we forget about that fundamental driving force. And if you can just align people, remind them that people matter more than profit statements, they get back to their roots, that they want to brag to their kids and grandkids about how they made America better. This is a chance, a generational opportunity.
Yeah. So, you know, there's a a whirlwind of things going on. So Part B premiums are increasing, and then you mentioned Part A, where according to the trustees report, there'll be about an 11% cut, perhaps, once the trust fund becomes depleted. So on the one hand, costs are rising and services may decline on the hospital side if the providers experience an 11% cut. With respect to Part A, what's the solution there?
Well, I could talk about this for hours, so I'll give you a succinct answer. All right. So, for-profit hospitals actually are bringing back mid-teens returns. Nonprofits are bringing single-digit low returns. Now, there's other reasons that may explain this, but at its very core, there are ways of making the system more efficient. And I think hospitals who are challenged, and the hospitals are the center of our communities, especially in rural America, which they're critical, and they're not getting much of the Medicaid dollar. Only about 7% of Medicaid money goes to the rural hospitals, so they get hurt badly in these programs. But at its very core, what these hospitals need to be able to do is use technology, which we're helping to launch on Wednesday at the White House with our effort to make America's health technology great again. It's an effort to make it easier for patients to interact with their doctors using their phones, letting doctors use navigation support so they can help with some of these difficult decision-making processes. Cancer drugs are changing so quickly, it's almost impossible to keep up. So how do we use the same technology that lets you pick the best video to watch tonight based on what you saw yesterday, use a rideshare technology, use Airbnb technology, use modern tools that have made the banking system safer from fraud, waste, and abuse, and allow that all to play out. It starts with two fundamental realities. You have to know who your customer is. So we've got to be able to allow the American beneficiaries to validate who they are and then allow the system to talk to them with their medical records. And you also have to get doctors to tell us where they practice and who they are. Don't replace the doctor. Use AI to expand the doctor's opportunity. Allow them to use AI to do the intake so they pick up subtle problems with your emotional issues and how you're not taking your meds and why not and the other issues of your life. Give it to the doctor in an organized fashion so that when they're with you, they actually give you answers. They're not just listening to you.
All right. You already answered the question I was going to ask about AI. So try this one. A federal judge recently blocked a rule that would have removed medical debt from credit reports, and that would have helped maybe 15 million Americans. So curious, how do you respond? And what's your message to patients who might be stuck with debt that is affecting their credit reports?
Number one cause of bankruptcy in America is a health issue. Number one. And the number one driver of aging, it turns out, are financial issues. If you include things like divorce, which often present with those kinds of catastrophes. So we have to deal with the medical debt problem, which dwarfs all of the debt that we have. We also have to deal with it by reducing what it costs to get care in America and by empowering people to know what it's going to get, what it's going to cost. The No Surprises Act did just that. We just never actually enforced it. So we have laws now that are out there to protect patients that have not been used, and hospitals should be able to tell you ahead of time what it's going to cost. You should be able to choose accordingly. We should have protection on some of these expensive drug platforms that you might not realize you're walking into. But the American people are powerful if you arm them with information. Interestingly, the healthcare marketplace really isn't a marketplace because in a marketplace, you have willing parties with full information flow, right? You don't buy stocks in a vacuum. You know a lot about the companies and it's mandated and then it's also enforced. We don't do that in healthcare. That's one of the big opportunities with the digital transformation of the system. Because once you have transparency, you'll say just that hospital across town charges half what they charge at my hospital for an MRI scan. I'm going to complain to my doctor. And guess what happens? The doctor calls the hospital administrator. They drop their MRI costs. The whole system does better.
I would agree with this. Meaning that the issue is that in economics, there's the idea of transfer price, right? Inside of minestrone soup are tons of ingredients. It's not clear how much navy beans are. It's not clear how much oregano is. It's not clear at all. And what ends up happening is all we get is the can. Well, that's fine, but we're not quite sure whether or not one of these ingredients here we're being massively overcharged for. And that's what he seems to be talking about here. Whether technology, we do have an act. He admits, Dr. Oz admits that the No Surprises Act isn't enforced. which is the first time I've really ever heard that. So shout out to him and compliments to him for being more candid about that. The rest of the interview was about Dr. Oz's possible political aspirations and things like that. Hopefully you've liked today, got something from it, got some extra insight, saw a sneak peek behind the curtain when you have these interviews going on. Be sure to like and subscribe. There's also another channel called Jay's Corner where, this is a Medicare specific. That said, there are tons of other topics that I have opinions and information on, as you can see by the left-hand column, other right. The left-hand column on your screen. I'm also Education Fellow at the Alliance for Lifetime Income, nonprofit which educates advisors and consumers about the usefulness of guaranteed income under retirement. Email, links, everything you need below. Be sure to like and subscribe. Share it with somebody else. Thanks.